Good evening, everyone, and welcome back. My name is Rich Riley. I'm a member of University Hospital's Marketing and Communications team, and I'll be your moderator for our event. On behalf of the entire University Hospitals family, thank you for joining us for our webinar on how to conquer chronic pain. According to statistics for 2018, 50 million US citizens, or a little over 20% of adults, are living with chronic pain. In fact, the overall chronic pain prevalence in the US is higher than that of diabetes, heart disease, and cancer combined. Living with chronic pain is difficult. It has a negative impact on a person's quality of life, mood, and stamina, and leads to stress and poor health. You no longer need to live with chronic pain. Tonight, we'll learn about chronic pain in adults, its causes and options for non-surgical and surgical treatment. Together, we can help manage your pain and get you back to doing the things you enjoy in life. A few housekeeping notes before we begin. In this platform, all attendees are muted. While you won't be able to ask questions through your microphone, please note the Q&A function at the bottom of your screen. If you have a question that is not addressed in the presentation, please submit your question through the Q&A function, and our presenter will address questions at the end of his presentation. Also, today's webinar is being recorded and will be available for viewing on demand in the near future. It will be posted on our website, and as an attendee of this evening's session, you'll receive an email with that link contained within it. It is now my pleasure to introduce our presenter. Dr. Kutaiba Taba is a renowned pain specialist and recently joined University Hospital's Parma Medical Center as its new director of the Pain Management Center. Dr. Taba comes to UH from Metro Health, where he led their pain management program for decades and instructed generations of medical students, residents, and fellows. Board certified in pain management, anesthesia, and surgery, he's a widely published physician and a prolific guest speaker, and has consistently been named among the top doctors in Cleveland Magazine's annual listing throughout the past decade. Dr. Taba has experience with a vast variety of interventional pain therapies, including radiofrequency ablation that applies heat to nerve tissue to decrease pain, kyphoplasties, in which a balloon-like device is inflated to create space that is filled with cement to relieve compression fractures in vertebrae. He is also well-versed in implantable therapies for chronic back pain, such as spinal cord stimulators to block nerve signals from reaching the brain, intrathecal pumps that deliver pain medicine directly into the spinal fluid. Dr. Taba has also developed an IV infusion therapy treatment that relieves central neuropathic and fibromyalgia pain. This treatment can help decrease reliance on opioid narcotics. Dr. Taba completed his fellowship in cardiothoracic surgery at the Cleveland Clinic Foundation and worked as a cardiothoracic surgeon at St. Vincent Charity Hospital before shifting his focus to anesthesiology and pain management in the early 1990s. He served as Metro Health's Director of Pain Management continuously since 1992, with the exception of a 3-year stint at the University of Arizona from 2002 to 2005. A native of Syria, Dr. Taba is fluent in Arabic. Ladies and gentlemen, I'm very proud to present to you Dr. Kutaiba Taba.
Well, thank you, Richard, for your nice introduction and information about pain management as well, and its impact on the society. I'm really honored here to be with you guys, and I love to discuss with you this important topics that affects a lot of us, young and old. And I know that everybody is worried about the COVID-19 and this epidemic, and there is no doubt about it. It's a horrific epidemic. It's already more than 100,000 people have been died from this epidemic. I want to assure you that I see from my office, the sun is up. We are opening our hospitals gradually. Our country is opening. We are using every precaution at University Hospital, at Parma Medical Center, and our pain institute actually to prevent any transmission of COVID-19. And I really believe the safest place to be around now is the hospital, because we are really very, very cautious about everything between social distancing and wearing a mask in addition to testing. So I want to assure you that we are fully operational in office visit, procedures, and operating theaters. And we love to have you around to help you with your pain and your pain needs. Before I continue with my discussion about the pain management, I'd like to introduce myself and who I am and what's my family. This is my family almost 20 years ago. This is my son in the middle, and I have 4 girls. Myself in the back and my wife next door. We were in the university, and we were in Grand Canyon during Thanksgiving when I was at the University of Arizona. I am born in Damascus, the oldest capital in the world. I'm a grass-fed, so I'm Ohioan now. And I'm 1 out of 8. My wife, Barbara, she is Irish, Italian, and she is 1 out of 8. And we stopped at 5. We didn't continue to 8 at this time, but you know, there is future. Anyway, I really want to introduce you to my kids and my family. So next, you're gonna see these kids. Now they are adult. Oh my goodness, look at this. This is my son's wedding, which was 3 years ago. This is his wife, Crystal. My son is Omar. My wife next to him is Barbara. And this is my Susie Q. Suzanne, she got married 2 years before him to this wonderful guy, Olson Horton, who is an amazing guy. He is like my son. Actually, I gained a son by her marriage, and thank you for Olson. And this is my nephew, Izzat, who is really an amazing IT guy, but he is like the solid friend, family member, son, and really a great person. Now, next to me here, this is Lena, and this is Serena, and this is Jenna Marie, and this is, of course, the handsome guy is me. Ha, ha, ha. And before I have to introduce you to newest generation, this is Aurelia, and this is Thea. They are my son's kids, and they are beautiful young ladies. Now, since you know about me, we're gonna go ahead and proceed with the lecture. Pain crises affect, like Richard said, a lot of population, 50 million people affected, and that number is going to continue to grow up more because of the increased life expectancy. Increased life expectancy, that means there is increase in wear and tear in our body. So that means we're going to have more pain because we live longer. The other thing is that patient that when we get older in age, we get exposed to multiple cancers, and these cancer treatments or the cancer itself may be the cause of pain. So really, pain management is only going to grow more and more. The pain complaint itself account for 20% of all clinic visits. But if we take the pain itself and add the pain complaint added to the other complaint that the patient come over, like for example, patient goes for diabetes, but they have complaints of lower back pain. The main visit is for diabetes. We will see that the pain complaint, in addition to other complaint, is around 80% of the visit. It's a very huge number. Now, the analgesic prescription count for 12% of all prescription, which is second to the cardiovascular, prescriptions. The $100 billion a year being spent on chronic pain, at least $100 million. And chronic pain is the source actually for multiple excessive surgery, from fusion to refusion, to another fusion, extending fusion. It's just really, it goes and goes and goes and goes. In addition, it is the leading cause for disability and loss of jobs. And of course, it's the family demise. Before we continue our discussion about the pain, we have to discuss what's the definition of the pain. Everybody has talk about pain in different ways. You know, you may tell your husband, oh, he is a pain in you know what, and you take your kids and stuff. But you know, the pain has a clinical definition according to the International Association of Study of Pain, which is our body of really studying pain. This association said that pain is a sensory, like any other sensation in our body, touch, smell, everything else, that associated with emotional So it has emotional aspect. Even when you are born, acute pain, whatever pain happened to us, it has an emotional aspect and become an experience, which experience that become a memory. That means this memory is registered in the brain. Now, every time a memory of the pain, you may result in pain. Any emotions associated with the pain result in pain. One of the things that we do in pain management, try to separate this from each other. It's associated with actual tissue damage. That means we can find a damage. We can find a broken bone, or we can find a disc herniation pushing on the nerve. Or we may do an MRI, we don't find anything in the back. Or a patient has a migraine, we do MRI, we do all kinds of studies, we can't find any tissue damage. It doesn't mean he's lying. It means that it is associated with actual tissue damage or described in such damage. So I hope you do like this definition of the pain, because it's very good. Now, after we talk about the pain, we're gonna talk about pain transmission and how we understand pain. The pain pathways actually did not discover until the 17th century, until René Descartes stated that the pain is really actually, most of the people, most scientists or philosophers before that, they thought that the heart is the center for emotion, center for brain, center for understanding, because of course your heart flutters whenever you're sad, happy, whatever. Anyway, so Descartes said that there's a long fiber running from the foot to the cavity in the head. That cavity in the head send the fiber back to the periphery to pull the muscles away from the damage, from the burning area. And he is the philosopher that taught us how to think, not how to think, how to analyze things and how to question around us so we can find the truth. Cogito ergo sum. I think, therefore I am. That's really essential part of philosophy that started at that time in the 17th century. They were awesome at that time, actually, the French philosopher. I don't know what happened to them now. But anyway, the pain system is like any other system, like the cardiovascular system, like the vascular system, like the pulmonary system, the kidney system. It's a system. It's a closed system that has check and balances. There is ascending fibers, which is the signal comes from the dorsal root ganglia, which is the neural cells that they are sitting just next to the spinal cord. They send limb to the periphery, become a nerve. That nerve carries the signal, modified sometimes in this cell, and then it goes to the spinal cord. While in the spinal cord here, there is some place called wide dynamic range neuron, that collection of cells modify the signal, adjust that signal, and then the signal transmits up to the spine, from the spine to the brainstem, to the thalamus area, to the brain itself, the old brain or the new brain we call it. And then from there, a signal comes down to the spine, and that signal suppresses or enhances the signal that's coming from the periphery. And this system is a closed system. It's going all the time. So it is very important to understand that there is hundreds of mediators, hundreds of transmitters that work on electrical and chemical reactions, try to get this system going and preserve our sensation of pain and protect us from pain and help us understand the pain as a body. Now, pain itself is really no evil. Pain is good. Pain is essential to our survival, not because I'm a pain management doctor and I benefit from treating pain, but really pain is very important. I'm gonna tell you why. This is an example of kids that they are born with congenital abnormalities that they don't feel pain. So this is called CIP, congenital insensitivity to pain. These kids, they cut their tongue, they burn their finger. This little girl here, she put the pencil in her face, went to her cheek, and she didn't feel it. This kid here is only 14 years old. Every joint in his body is damaged because there is no feedback from his body to tell him to tell the nervous system, the body, what's going on with this joint and stuff like that. And this happens actually in adult patients. That could happen similar to that. It's called Charcot disease, which is the joint when they have severe neuropathy in the joints and the joint doesn't feel, it becomes joints like this. So pain is really essential to our survivability and the tissues to survive. So acute pain from that perspective is an adaptive beneficial response necessary for the preservation of tissue integrity. It is an important factor. It's an important function in our body. It's like our heart beating. Pain is essential in our survivability. The thing is the chronic pain. It's a pain that outlived its usefulness. Now the pain is the disease itself. So everybody trying to find the source of a chronic pain. Sometimes you can't. It is chronic pain. We're gonna address that as a chronic pain. Now there's two theories about chronic pain. Some people makes it easy to think about, okay, it's an acute pain that 3 months later, boom, switch from at 12 midnight from being acute to become chronic, which is, in my opinion, is really useless. And, you know, I mean, it's not really logical. Just from 3 months goes from one state to the other. I consider chronic pain is like many other people as genetically predisposed disease start as a chronic pain. The problem is that when you start your lower back pain as a chronic pain, you don't have that lower back pain before. So it feels to you like it's acute. But you get the treatment, you get all that stuff, and the pain continues. Now, we say, okay, because it started acute and became a chronic. No, the chronic pain started as a chronic pain. And we think that in the future, we're gonna discover a lot of genetic component to this chronic pain situation. Now, why do we treat pain? Well, because beside the humane and the ethical aspect, there is major negative physiological and psychological consequences to pain. Pain really destroys the person. It destroys their life, their function, their ability to function, to move, their ability to eat properly, their ability to sleep. They became obese, they become smoker, they're depressed. A lot of things happen with the chronic pain that result actually in significantly decreased life expectancy. And actually Harvard School of Medicine, they had a few years ago, major study done, showed that there is decreased significantly in the life expectancy in the patient that they have a chronic pain compared to the patient that they have no chronic pain. So that's why we treat the pain. Now, before we continue and talk to you about the techniques and the exciting things that I'm doing in Parma and really the support that we are getting from the university, I want to tell you about my philosophy about pain. Pain management to me is not just a pill. Pain management to me is not just an injection. Pain management to me is not the fancy surgery or implants. Pain management to me is not the physical therapy or alternative therapy. Pain management to me is an art, like the medicine. It's an art tailored to each individual by their trusted pain specialist to preserve, regain, and improve the quality of life, accompanied by total patient involvement and empowerment. This is how we can do and how we can conquer pain, by working together. I do things to help you achieve goals. You do those goals and you work on these goals and you get better. This is how we do it, and this is how we became really successful. Now, pain management became in forefront because of the opioid epidemic and the pill mills that opened in Ohio, and there was a lot of confusion about pain and what's going on, and to start confusing about pain management and addiction. I want to emphasize to you that there is a big difference between addiction and pain management. Addiction is a disease. It's a neuropsychiatric disease that is a genetic predisposition to it, and sometimes it has social things attached to it, but it affects around 15 to 20% of the population. I'm not talking about cigarette smoking either. And this is without cigarette. I'm talking about alcohol, drugs, and all that stuff. So that's a high percentage. And addiction doesn't know societal level. You could be rich, you could be poor, you could be on the street, you can be homeless, and you could be addicted or you could not be addicted. If I'm giving you here an example in the picture about the Queen Victoria, she used to love her cocaine and her laudanum, which is opium with alcohol extract together. She didn't have much problem, but her daughter Helena, she became addicted to it and really had major problems. So addiction is really old things. It's going there. It's not really related to pain management. The people that use opioid in pain management for the long term, they may develop opioid use disorder, which is something we will discuss in a little bit further if we want, and we can discuss it in the discussion. This is the Recovery Research Institute. try to identify who is the people that they have opioid use disorder. We find out from this graph that around 60% of the patient that they have opioid use disorder use it for recreational or for not pain-related issues. Only 15% of the patient that they had history before that of substance abuse, that they were in recovery and they have injuries happen to them acutely, they end up on opioid and they get relapse. But nowadays we have actually significant programs for these patients. We have a great plan for them. We do it pre-operatively, intraoperatively, and post-operatively, and we get them back with their recovery resources that they need. So the World Health Organization had an old ladder for pain management protocol, start from different levels, but that really did not represent the actual ladder for pain management. Since that this ladder is really does not reflect what's going on with the chronic pain patient and the technology that we have. So our ladder now, it has start from small NSAID and Tylenol and neuropathic pain agent to interventional therapy. We send them to corrective surgery. If it doesn't work, we go to neuromodulation, spinal implant, long-term opioid therapy, maybe for a short period of time. If it doesn't work, we go to intrathecal therapy. I want to emphasize to you that any technique that I use, any step of this ladder that we use, we're going to have you involved with the physical therapy, integrative medicine, and behavioral health. And that's what strengths of our exciting program that I'm going to show you now. In Parma here, finally, we have the Comprehensive Pain and Healing Center. We're going to have really an exciting program. We already started that. We have a pain triage center that is going to have, we have a great pain doctors at the Parma already exist here. We have Dr. John Shalusky, who is very well known here. He has been here more than 30 years, and thank God he is not retired. He has a lot of followers. Everybody knows John. And Roger Gumber, who worked with Kaiser HealthSpan, and now he is at the university, who is terrific doctor that he's doing great job in the pain management already here. And then we have Dr. Singh, who came from Michigan, and he is here. He has years of experience from interventional to medical management. And of course, there is myself. But the Pain Triage Center is not going to be ourselves only. They're going to be the Connor Institute of Health. It's going to be the chiropractor that they are coming from the Connor Institute of Health. They are going to be the primary care physician. Yesterday, I was talking to primary care physician and how we're going to partner with them to create liaisons in every center so they can send the patient to us in a way that we can cooperate together back and forth and help our patient. We're going to have a patient liaison to take the patient from one place to the other. So the patient navigator will help us keep the patient on task. We are having, I don't know if you know about the Connor Institute of Integrative Medicine. The Connor family is the Sherwin-Williams families. They believe in alternative therapies and in the body healing itself. And they wanted to really develop an institute that represent these ideas of natural healing. So they actually donated a lot of money to the university hospital. Lucky me, I came to benefit from that. So Dr. Adan, who is Francois Adan, she is the center director. She was excited about my ideas of coming over to the university and doing these programs here. And she is going to be part of that institute. Actually, in a couple of months, or less than a couple of months, we're going to have a chiropractic care, massage therapy, and acupuncture. We have the Institute of Pain Institute from the University Center itself with Dr. Janada and Dr. Lakam. They are sending us really a great behavioral physicians that we're going to be able to help with our patient. So we have really collection of therapy that we're going to provide for you. And you, for sure, you're going to find something you're going to love and you're going to like. In addition to what I said, we're going to have osteopathic manipulative medicine, which is manipulation by osteopathic physician. We're going to partner with the PCP. We have already developed IV infusion therapy for the patient that they have chronic pain, central pain syndrome, fibromyalgia. We are bringing one of the greatest doctors that she is trained in pain management PM&R, and regenerative medicine. We're going to be able to use PRP and bone marrow aspirate injected around the tissues, the injured tissues. I am so excited. It's going to be an amazing program. We are in the process of building it gradually, but we have a lot of the parts that's already in now. So you're welcome, guys. I mean, it is really awesome. So I'm going to go now over the interventional therapies that we usually do. Everybody knows about epidural. Epidurals, you know, women have epidurals for their babies. You know, my wife had 5 epidurals, you know, so everybody does, and many people say it epidural. So anyway, the great thing about the epidurals that we do nowadays is we don't do it blindly. We do it under X-ray, and we target the epidural toward the area where it's affected. So if we have a foramen here, that's where the disc is pushing on the nerve here, and this is the nerve at the L5S1. We inject the medication directly on the side, and that will give a great pain relief. This joint here is the facet joint. These joints in the back, it's like the joint in the knee. It gets arthritis, or it gets damaged by car accident or something, or lifting. So we can go to the nerve that goes to this joint, and we put needles there, and we microwave those nerves. And the pain goes away from that affected area for 6 months to a year or something. But we give the patient window of opportunity so they can rebuild themselves and improve themselves and move forward with the next step. One of the great procedures that it is just developed recently, actually, is called the Intercept procedure. In the Intercept procedure, it goes actually, the idea behind it, let me explain first, that we used to think that the pain is coming from the disc, that when the disc damage or the disc herniate, that's where the pain is coming. So we used to do a lot of discographies and IDET procedure and stuff for axial pain. Axial pain, that means the pain in the back itself. Now we understand actually that the pain comes from the end plate, from the bone itself. So the nerves that comes here from the sinoatrial nerve comes from there, goes from this area here, goes inside in the middle and sprout up and down to the level there. And that will carries the pain impulses from the bone itself. So now what we do is we go like the kyphoplasty, we go into the bone itself here, we put the catheter, and then we do radio frequency and we microwave this nerve here, and that gives amazing result of relief of pain. So this is a new technology actually, just starting this year. Implantable therapies are couple of implantable therapies we have the neuromodulation. Neuromodulation principally is a technology that we use electricity to modulate a signal in our body. That signal could be movement disorder. You know about it from Parkinson's disease, that they have deep brain stimulation, that they do that for Parkinson's disease. You know about it for patients that they have depression, they use it for vagal nerve stimulation. There is a lot of, you know, bladder. The women that they have incontinence, they use bladder stimulation, sacral nerve stimulation. So the neurostimulation and neuromodulation is a big thing, and it's going to be advanced further and further actually in the future. We use a lot of these technology to decrease the signal, to use the electrical signal to modify the electrical signal that's causing the pain. The other modality is an intrathecal therapy. The intrathecal therapy is we put the catheter directly to the spinal fluid, like this here, and this one tunnel the catheter and connect it to a pump. And this pump will deliver the medication directly to the spinal fluid where it's supposed to work and gives the patient really a great pain relief. One of the exciting thing I was telling you that I have actually in IH grad that I'm working with the team in Metro and FES Center, that on the VA, that we are taking actually patients that they are quadriplegic patient, that they cannot breathe, they cannot cough. So what we do is we put electrodes, that neuromodulation, the same thing like this electrode in their thoracic spine, and we generate a lot of energy that makes the chest wall and the abdominal cavity squeeze. So we generate, actually restore the cough reflex for them. And these patients, they do amazing. I mean, it is really absolutely stunning. I mean, imagine for a quadriplegic patient going to the hospital every month with pneumonia and stuff, and now suddenly you can take the trach out, they can sit down, they can breathe comfortably, and actually the side effect from that, they start the defecation, actually, they're pooping, instead of 4 hours, it went down to like 40 minutes. It's really amazing technology. So neuromodulation is beautiful things that we are using it in every aspect in our field nowadays. We talked about the mechanism. Now, when I started in the 1991 or 1992 doing the implant for spinal cord stimulator, we used to have a single generator that has a battery in it, and whenever the battery is done, boom, it's dead. And the battery did not carry a lot of juice because technology at that time wasn't there. And the stimulation itself didn't have strong. And we have external unit that we have a receiver and an antenna outside, and the patient has to always marry to the receiver from the top and to keep that stimulation going. Then the technology improved. Now we have rechargeable generators. Now the newest technology is the high frequency, which is principally we are generating a very high energy, 10 kilohertz of stimulation, that the patient would not feel anything, but it's a create in the spinal cord, it creates a track, really beautiful track of energy that suppresses the chronic pain, especially for lower back. It has we have a great successful result. And this new generator that we have could really simulate any other stimulation that we need. This technology could be applied for peripheral nerve stimulation, from headache to migraines. This is an example of a patient that she has surgeries on her neck that didn't help, so we put this lead here for the neck pain, and she had secondary fibromyalgia from all the medication she took and all that stuff. So we put this one here, and this one stimulate the whole body, and that give her really a great pain relief. This is a patient who had surgeries on his neck and his back. Both of them are resulted in chronic pain in both areas. So we put in the same generator, we have the same generator that can carry 4 of these leads. So in the same time, we put 2 in the neck and 2 in the thoracic spine, and he's doing great from these procedures. This is a patient who has S1 and he has a fusion in the top here. So we can't go to the nerve root down there. We went down from the bottom up. And this approach, we use it for pelvic pain patients. So if the patient has a pelvic pain, nerve injury after hysterectomies and stuff like that, we can do that as well for them. This patient has also lower back pain, so we put peripheral nerve stimulation for their lower back pain. And I mean, these cases I'm talking about has been years in function. Now, intrathecal therapy, it's very interesting. 1 milligram of spinal morphine, 1 milligram of spinal morphine equal in potency to 300 milligrams of morphine by mouth without a side effect. So the nausea, the constipation, all that stuff would decrease significantly. But opioid is opioid. The patient gets used to it. Opioid-induced hyperalgesia, all that stuff that we see in the oral medication could happen in intrathecal medication. That's why we use something called polypharmacy. So we use a lot of other drugs associated with the opioid. We use local anesthetic, we use clonidine, we use baclofen, and there is new medication called Prialt. It's not new. I mean, I did the study actually in 1995. It was phase 2 study on this medication, and now just approved 5 years ago for intrathecal usage. It's from snail venom. It's calcium channel blocker, works on the nerve pain, and it is really novel idea to treat the pain for the patient that they are failed opioid therapy on every other medication, and for neuropathic pain and nerve pain. So this is the conotoxins from, from the venom from the snails. So the pump itself has also a programmable area. So in addition, you will have, the patient could have a programmer. He can push the button, and that gives them an extra pain medication. We program it. So the patient, for example, is working hard, going in the ER, doing some hard work, comes back, his back is killing him. You push the button, that will give him an extra dose of the medication. I want to share with you a story that it is really amazing story. It's emotional, sad, but in the same time is happy. This is a Hispanic couple that came to my office. She is 42 years old. She has colon cancer with metastasis to her hip. She came, she is sleeping on her husband's shoulder. When I wake her up, she screams in pain because of the bone, the metastasis to her bone. I mean, poor woman. So I immediately called the hospital. I admit her to the hospital. I called the insurance company, begged them to get immediately approve her for intrathecal therapy. In the same day, I put catheter in her spine, tunneled it, and I connected to a pump. I gave her medication. When I left the hospital in the evening, she was comfortable. I come back in the morning. She's sitting in the bed eating breakfast. She has her 5 kids, young kids around her, her husband sitting on her bed, and everybody laughing and happy and all that stuff. Down the road, a few months later, she died, of course, from her cancer. So I never expected that. My secretary, actually, she brought the newspaper, and she brought that, and her husband wrote in her obituary, "My wife passed away after 2.5 years of fighting colon cancer. I thank her doctors for trying to cure my wife's cancer. I would also like to thank the pain specialist for taking my wife's pain away. They made it possible for my wife to enjoy life to its fullest. She was able to laugh, talk, and sing to the very end." This is the beauty of what we do in medicine. This is the greatness. That's God give us this gift to help our population. And this is really something so amazing. Life is not a quantity, it's a quality. And we can really make the quality so good for our patient in pain management here. So I'm gonna go quickly over research in pain management and the new future technologies. I believe that the neuroimaging is gonna be the biggest thing in in the neurology, in the psychiatry, and understanding the pain itself. One of the studies done recently showed that the patient that they have PTSD, they may have a focus of an area that it's only lit into this magnetoencephalography. So the future is in understanding the brain and the brain mechanism and the brain function. We know now from the functional MRI that there is areas in the brain that has whereas they feel heat, and areas that feels cold. So it's really all of that available. Neuromodulation, like we talked before, is going to be big. We already have deep brain stimulation for Parkinson's disease. We use deep brain stimulation for also chronic pain syndrome, and we have cortical stimulation and a lot of other stimulation that we are doing. Gene therapy, we already have in the University of Michigan, they have studies done. They had the patient that they had the virus of the shingle virus, changed the gene in it, injected it into the nerve endings of a patient that they have lung tumors involving their ribs, and that's very painful disease. And that works amazing on that pain. So there is a future in gene therapy in pain management. All of that, I want to emphasize to you that this is John Bonica's statement, who is a mentor of my mentor, Dr. Melvin Lucas. Bless his soul, man. He was an amazing guy. I learned from him everything. Finally, and perhaps the most importantly, the acute pain model where the passive patient is healed by the active physician must be abandoned in the chronic pain situation. The patient must become the active component and accept the challenge of becoming well. Now I'm gonna give you a few things to laugh about. I used to have really a big, nice black mustache, a huge one. And this is at the University of Arizona in the first year there. During Halloween, all my staff put the fake mustache there, and we are accepting the patient there in the office, and everybody liked this. It was really hilarious. And of course, to continue with that, this is one of my classes of the resident graduation. And I used to be a lot heavier than now. I used to love my food, man, I used to eat the wrong type of food. And this actually, 3 of my residents here, they became pain management doctor. And one of those residents, actually, he's my boss now. Holy cow, I hope he's not watching. And I thank you very much. And this is my little Aurelia sharing her ice cream with you. If you have any question, please go ahead and start now.
Great. Thank you so much, Dr. Tabah, for all the information. Again, for all of us, all of you listening, Dr. Tabah has 2 office locations, one at UH Parma Medical Center and another at UH Parma Medical Center Outpatient Rehab. And that's actually located at the North Royalton YMCA. If you'd like to make an appointment with Dr. Tabah or his colleagues at UH Parma Medical Center, please call 440-870-1234. 9508. If you are not in close proximity to UH Parma Medical Center, you could always go to uhhospitals.org/pain, and you'll be able to go to the website and find someone close to home. So we do not have any questions. I don't know, Dr. Tabat, if there's anything else that you'd like to add?
I didn't understand, Richard.
So there are no questions that have been forwarded in. I didn't know if there's anything else that you'd like to add, and we'll wait here a few more minutes to see if anything's submitted.
Oh, absolutely. I mean, there is a lot of exciting things happening in the pain management. You know, when I did cardiac surgery, what my excitement about cardiac surgery was the amazing things, the development in the 50s, and how DeBakey and Beggy and stuff like that, what they did. I mean, Dr. K at St. Vincent Charity Hospital, to have a cardiopulmonary bypass to correct congenital heart disease, connected the mother to the baby arterial and venous system. So the mother goes to sleep, the baby goes to sleep, they connect both arteries, and they go and close the VSD or something so quickly and stuff. So it was really a primitive area when I went to cardiac surgery, and I was so excited about it. After a while, actually, it became very routine. I mean, I start to remember the areas that I used to do trauma and open the belly, don't know what's going on, and then it gets excitement for it. But to me, when I got exposed by Dr. Melvin Lucas, my mentor, about the pain management, I found it is exactly the same thing. It's a very exciting field that I never knew about. I never knew about all these things. I mean, it was very simple. Patients have surgery, you give him a couple of Percocet, go home, you'll be fine, man. That's it. You know, nothing major there. And up till now, actually, it's a chronic pain management. It's in the infantile stage. And still, every day we have a lot of technologies, a lot of improvement happening. And I really see the future in pain management is only going to happen bigger and bigger.
Great. Well, first of all, there are a few thank yous that have come in. So people really appreciated your presentation. One of our participants said, thank you for all that you do. You really helped my husband. So that's nice to see. I have a question for you. What is recommended for fibromyalgia pain? Well,
really, the exercise is the most important thing. Many people, in fibromyalgia, what happened to fibromyalgia, we don't know what the disease is. We call it a neuromuscular disease that affects the nervous system and the muscular system. And it's the same thing. It's a disease that affects any type of population. And sometimes it comes after chronic illnesses, like after having long-term infection, sometimes after major surgeries and stuff like that. And the patient, what happened with fibromyalgia is like one day they feel good, they do everything. They do laundry, they do dishes, they clean the house, they go shopping, they do all that stuff. And then for a whole week, they don't get out of bed. So having the chores done every day, certain chores, is very essential for fibromyalgia patients. I recommend a lot of supplement for fibromyalgia patients that help them with their supplement. I recommend a lot of anti-inflammatory diet for these patients, weight loss, and pool therapy is amazing things for fibromyalgia patients. And we have actually at the YMCA one of the greatest pool, and inside the pool there is actually a treadmill. So it is really amazing exercise that the patient could utilize at the University Hospital, North Railton, Parma Center. In addition, we developed the IV infusion therapy that could help a lot of fibromyalgia patients. I'm not saying that this infusion therapy help everyone. Of course, I mean, like we talked about, I mean, it's like the treatment has to be tailored. We are dealing with the human being. We are not dealing with disease. We don't treat symptoms, we treat the human being. And every human being responds to different things. But most of the patients that they have fibromyalgia actually responds very well to this IV infusion therapy. So from that perspective, in addition to massage, chiropractic care, stuff like that, which is all of it, we're going to have it here. Acupuncture is going to be another modality that could help with these things.
Great. Another question. We have someone who's waiting for shoulder replacement surgery, and they want to know, is there a pain management program to help with the pain while waiting for shoulder replacement surgery?
Yes, we do certain injection on the nerve outside the joint. It's called suprascapular nerve, that we can inject that nerve, and that helps a lot with decrease the pain in the shoulder itself. In addition, there is some stimulator that we can use them for 3 months actually. You can put that stimulator over the nerve itself and you do the stimulation on it, and that also help a lot with the pain. And then you can take that lead out later on. But so there is things you can do absolutely until you get to the shoulder surgery. And the shoulder surgery now is amazing. We do it's a reverse shoulder replacement. So it's instead of the head on the humerus, the head will be going there, and the other side goes down the other way. It really helps a lot of patients, and they can't sleep at night. Most of the patients, the problem with the shoulder, they can't sleep. It's like every time they turn, hurt like hell.
Okay, thank you. So we know there are lots of supplements out there that claim to be miracle drugs and take away your pain. And we have a question centered on that. It says, I have used curcumin and turmeric for aches and pain. Do you have a suggestion in regards to these supplements?
No, I think it works. My wife is an herbal medicine specialist, actually. She has a master in herbal medicine, and she is a critical care nurse and paralegal, actually. But, I mean, she gives me a lot of supplement for me. I have a lot of joint arthritis as well, and gives me a lot of energy and helps me a lot with and I believe in supplement. I really believe. That's why I wanted the Connor Institute to be part of us, because I really believe in integrative medicine, and I really believe in supplements. So yes, if the supplement helps you, absolutely, it's very good things to use. And there is a lot of supplements, and that's something that I really cannot go into more details about it. I have pamphlet about it. I can give it to the patient, but there is a lot of supplements could help. Yes.
Great. Now, I believe this may be, we have two questions, but I think they're from the same person. The first is, I have been diagnosed about 20 years ago with Paget's disease. The second, have you ever treated fluoroquinolone toxicity, and is there any help for it?
I have not done that, no, but I treated Paget disease. I had a long time ago, actually, I had a patient that she had the Paget disease, and she used to break every joint of her body. I mean, every bone in her body breaks, you know? So eventually she had multiple broken the pelvis and stuff like that in the spine. And I ended up doing an intrathecal pump for her, which is the pump that we do for the pain. And actually she was very, very comfortable. Her mother, she was like probably, when I treated her, she was around probably 35, 40 years old when she had all these multiple fractures, really getting a lot worse. And her mother was 90 years old. She used to take care of her. She used to have so much pain in her lower extremities. She used to hit the wall by her feet all the time. And she has holes in the walls from just trying to make the pain subside. And I was really able to help her with these medications. So, I mean, yeah, I mean, there is sometimes we get lucky. I mean, I don't know if I can simulate that all the time, but I mean, we do our best.
Great, thank you. Another question. One of the things that you mentioned that was very interesting and I think resonated with our attendees is that you're talking about the patient needing to be active participants in their care. The question is, do you find that more patients are open to being active participants in their care, or does this need work?
No, actually, I'm really able to convince my patient when they come and see me and talk to them and explain to them actually about their pain and what's going on. And we go over things. And I use myself as an example. I used to be, 75 pounds heavier than what I am now. And I have a couple of compression fracture that I had a few years ago. Her name was Jet Ski. So damaged my back, and I have a spinal stenosis. Then I had major arthritis in my knees, and my right knee was horrible. I used to walk with my dog. My dog is 15 years old. He is limping, but he's able to move, and I am not able to move. So I decided to go on a certain diet, which is anti-inflammatory diet, and mostly protein diet, and what you call it now is the keto diet. Not really keto diet, but it is modified. Anyway, and I went into a pool. I started doing pool exercises, and I really worked hard. After I start losing the weight, I start able to walk more and more and more. And I had my knee replaced around a year and a few months ago, and now I can walk 5 miles, 6 miles. So I use myself as an example. There is no time it's too late to do something. It is not late. we have to really recognize that our body, we have to respect our body. When we are young, we don't give a damn. It's like always, we do anything we want and the Lord is gonna take care of it and we are indestructible. Until we get in the middle age and the things starts going really bad. So anyway, yes, I really find that many of my patients I'm able to convince, yes.
Great. I had a question from a medical student. It sounds like they're involved in the field of pain management. They want to know, how can we distinguish if acute back pain will become chronic?
Okay, they are talking about the theory about the acute becoming chronic or the chronic is a chronic. That's what the two theories that I was explaining, that you cannot really tell in the beginning if the pain is starting as a chronic or starting as acute. The patient never had a back pain and suddenly he has a back pain. So you're gonna say, okay, that's a back pain. We're gonna treat it with this standard of practice. We're gonna put them in a physical therapy. We're gonna give them NSAID. We're gonna give them muscle relaxant. We're gonna put them in this and that and stuff like that. It didn't work. We did an X-ray and stuff like that. There is a possibility of facet joint, disc here, disc there. We do injection. That didn't work. We do this, we do that. So now we're putting in the situation into a chronic. So the theory behind it is that this genetic predisposition for this disease is started as a chronic, but the presentation is acute because it never happened before.
Okay, thank you. Another question. So we have someone who looks like is out in Geauga County, and they want to know if any of these therapies that you discussed would be available in the near future, for example, at Geauga Medical Center.
I hope so. We are trying to implement this experience at Parma Medical Center. So this is going to be the first center that we're going to have this program from the Connor Institute and the Pain Institute working together in one place with our team. And hopefully whenever this one is stabilized and running really good, and we see the success we are having, we can simulate that in Geauga County, in Lorain County, in multiple areas that university has.
Great. And to the individual who posed this question, for more information, if you want to go to uhhospitals.org/pain, P-A-I-N, that is a landing page for all the information about pain management within our system, and that should help you further answer your question. So, Dr. Tabah, that is all the questions. Wanted to thank you so much for sharing all the information and thank those participants for the questions that we received. A few reminders for our audience. We will be emailing you a link to view this session on our website very soon. Again, to schedule an appointment with Dr. Tabah or his pain management colleagues at Parma Medical Center, call 440-870-9508. And again, if you're some distance from Parma Medical Center, we have other locations conveniently located close to your home. Throughout Northeast Ohio. You can find those at uhhospitals.org/pain. Again, thanks everyone for attending. This includes this evening's session. We hope you'll join us again for one of our future webinars. And again, on behalf of the entire family, have a great evening. Thank you.
All right, good night and stay safe.